Thank you for coming to the Last Little Doctors meeting, Quarantine Edition. Before we started, we wanted to take a minute to thank the Harvard Med School students who so kindly volunteered to give this lesson to all of you today. They've created a really cool interactive lesson that's both educational and fun and tailored for students to understand. So during the presentation, we encourage all of you to keep your cameras on, and we'll be recording this session. So as we said, the session is interactive. So please make sure that your comments and questions are appropriate to the relevant topic being discussed. And you guys can take it away.
Great. Thank you so much, Sarah and Allie. We are so excited to be here with you guys today and super impressed with your club and everything that you guys have been doing during quarantine. So it's really such a privilege. I'm Rachel. I am a first-year medical student at Harvard, and I was very grateful and lucky to be a big part of creating this curriculum and creating the website. So I'm very excited to do this with you guys today and have some firsthand experience.
Thanks, Rachel. Hi, everyone. My name is Titi. I'm a third-year medical student, also at Harvard. And I'm super excited to be here. I love working with high school students. And I really hope that you guys enjoy the lesson and participate. And I guess we just wanted to start by, there's a bit too many people for us all to introduce ourselves, but we definitely want you guys all to participate and we want to get to know you. So we were just thinking of opening it up if anyone has any thoughts about this pandemic, this coronavirus pandemic that's been happening in general, or if you want to share something that you'd like to know about it, that you hope that we discuss today, that would be great.
You guys are welcome to raise your hands or just turn your microphones on. And I think Zara and Allie can keep an eye on the chat for us as well if you want to type in questions, and they can share those with us.
My uncle, he's also a doctor, and he was talking about something called herd immunity, and I'm kind of confused what that is.
Great, herd immunity. Yeah, we'll definitely talk a little bit about that at the end. So that's a great point. Thank you for sharing that. And I also saw another hand. I don't want to pronounce.
My name is Media, I think.
Perfect.
Hi. I would love to know more about, so I've seen a bunch of different estimates for how long the pandemic could actually last, and I'd like to know what you guys think, how long we might still be in quarantine, or if it's just going to be an ongoing thing that we'll just have to deal with like the flu.
Yeah, that's a great question. Also something that hopefully we'll touch upon throughout the lesson. Okay. Any other thoughts at all? Sure. Okay, well, without further ado, we're going to jump into the lesson. So how this is going to work is I am going to act as the attending doctor, so kind of the doctor in charge. And Rachel she's gonna play a bunch of different roles. The most important one is our patient. So she's gonna play our patient, and she'll also kind of play a resident doctor who also is in training and also helps to teach students. And you all will be the doctors in training, like the medical students who are working with us on the medical team to help take care of this patient. So with this ongoing pandemic, a lot of times we try to limit who is in the room with the patient just so that we're reducing the need for PPE, personal protective equipment, and we're also reducing exposure. And so I will go into the patient's room, and you all will be able to interact with the patient through the screen. Okay, any questions about that? Okay. All right, so we are a medical team of doctors in training, and we are in an emergency room, and we are about to um, meet our first patient. So why don't we go ahead and talk to the patient. Before we do, I wanted to know if you guys have any ideas about what are some of the things that you want to know from when you walk into a patient's room. What are some things that you want to know?
Their family history, like of disease.
Family history, great. That's a very important one.
If
And
they have any underlying medical conditions.
perfect. Why do we care if they have underlying medical conditions?
Oh, because it can worsen if infected with something like COVID-19 or anything like that. That's why my friend, he's immunocompromised, so he needs to he can't even go outside because his immune system is so weak that it won't be able to defend against COVID-19, and he has a high chance of death, so it's scary for him.
Yeah, that's a very great point. We found that people who with certain conditions are more likely to get sicker from coronavirus. It's very important to know if our patient has any conditions that might put her at an increased risk. So that's a great point, just like your friend. And then I see in the chat, symptoms, signs, medical history. Yep. Allergies, that's a great one, and one that I personally forget a lot, but is very important. How long ago they began to feel symptoms, also wonderful, and what medication they're on. Good. So it looks like we're ready to get started. You guys have some very important questions to ask our patient. So let's go ahead and talk to our patient. And there's a link in the chat that you can use to keep track of your notes. So as we talk to her, we'll want to write down important information. All right.
Hi, doctor.
Hi, Miss Doe. My name is Dr. Titi, and I'm working with a really great team of students, and they have some questions that they'd like to ask you. Is that okay?
Yeah, that's fine.
Great. Take it away, guys.
Hi, Jane. Are you on any medications currently?
Yeah, I am. I brought them all with me, but I take a couple of inhalers and I have to take a pill for my blood pressure. It's 4 letters. It's called HCTZ, but I know that that's for my blood pressure.
Okay, Jane. What's the reason for your visit today?
Yeah, thanks for asking. I am just really not feeling well, and I've been having a really hard time breathing. I just cannot catch my breath, and I have a hard time breathing a lot. I have a cough a lot of the times and cough up some gunk most days, and that just kind of comes and goes, but it's just been so much worse recently, and I just feel like I cannot breathe.
Miss Doe, do you have any underlying medical conditions in your family? And
Yeah, I definitely do. Well, I smoked for a long time. I'm 65 years old now, and I have been smoking for about 40 years. And the cough that I was telling you I usually have is from all of that smoking. So I have something called COPD, and that just means that because I've been smoking for so long, I cough all the time. I don't really quite understand what the doctors were telling me, but I know my lungs just aren't very good. But this just feels different to me. I don't know. Usually, sometimes I have a hard time catching my breath, but these days, even if I rest, I just can't seem to start feeling better. But besides that and my blood pressure, I don't think anything else. And my family is pretty healthy too.
Miss Doe, before we get into your medical history, can we ask you some preliminary questions?
Sure, that's fine.
How tall are you?
I am 5'4".
And how much do you weigh?
I think I weigh 130 pounds, but I don't know. My clothes have been fitting a little bit loose these last couple weeks. I haven't been very hungry.
Okay, and do you have any allergies?
I'm very allergic to shellfish, but that's it.
Um, okay, any other questions for our patient?
Have you had any
Yeah.
surgeries in the past?
Any what? Sorry?
Surgeries.
Yeah, I have. I'm trying to remember. Well, I broke my leg when I was in my 20s, playing basketball with some of my friends, but I haven't been doing that for a long time. So I had to get surgery on my leg, but other than that, nothing that I needed anesthesia for. I got a tooth pulled once, but that's it.
Okay. And Miss Doe, have you had any contact with anyone who's been sick?
You know, I live alone and I don't see a ton of people. I usually just stay home most of the time. So I can't really think of anyone. My neighbor down the street had the sniffles a couple weeks ago, and I think her husband was coming down with a stomach bug. But I was only at their house for maybe one afternoon a couple weeks ago. And other than that, no one, I don't think, has been that sick.
And I think I missed this, but when did you say your symptoms started to get really bad?
Yeah, I think it's been about the last week. I think that it's really started to get worse. And I've got to tell you, Dr. TT, I don't feel good. I am chilled. I always have to keep this blanket on because I just can't get warm. I took my temperature the other day and I think it was 100 or 101, and I just don't usually get fevers like that. And I just am really not feeling good.
Okay, well, I'm sorry to hear that. Hopefully we can get you feeling better. Um, if there are no more questions, are there any more questions for our patient?
One. Did you have any complications on the leg surgery?
I think it went pretty well. I had to do some physical therapy and everything after, but the doctor said it went well. And I take aspirin now because they had to put a rod in my leg, and they said that that was something that was important. But everything went fine.
Okay, well, thank you, Miss Doe. We're gonna talk amongst ourselves and we're gonna come up with a plan and we'll let you know, okay?
Okay, thank you guys.
All right, so who can briefly summarize what information we got from our patient? What's going on with her?
Jane Doe, she came in and she had a cough, hard time breathing, and her symptoms were getting worse, and that's why she came.
Great, that was almost a perfect one-liner. A one-liner is how we communicate information about our patients very quickly with one line. The one thing that you were missing is how old she is. So how old is she?
65.
Great. So we have here a 65-year-old woman with a history of COPD who's presenting with a week of difficulty breathing. What are some of the things that we want to know? What are some pieces of data that we might want to get, first of all?
Blood pressure, heart rate.
Perfect. What are those called?
Vitals?
Vitals?
Exactly, right. So we want to know her vitals. This is very, very important. Whenever you see a patient, the first thing that you really want to look at is their vitals, even really before you go see the patient, because if this patient were severely hypotensive with very low blood pressure, that might mean that we need to act even more urgently. We might not even have time to really sit and talk to the patient for that long. Okay, so let's go ahead and take a look at her vitals.
I have a question.
Yeah.
So for the vital signs, if she says she measured her temperature like last week and it was 101, would we write that or should we take it ourselves?
Yeah, that's a great question. I think you always want to get information like that yourself because things can change really quickly. And especially if her last temperature was a couple days ago, that's definitely something that we would want to look at as part of our vital signs in the office. And TT, do you want me to try to get the slides up?
I was just trying to see if I can. Let's see. Is that working?
Perfect. Yep, you got it.
Okay, great. So who wants to interpret these vitals for us?
I think for a 65-year-old woman, a 95 BPM heart rate is a little bit high.
95 is within the normal range of 60 to 100. It's definitely on the higher end of normal. And most people probably are closer to like 70 or 80. So it is a little bit high. You're right.
Her rate, her breaths per minute is high, like it's higher than average.
I have a question.
Sure.
Like for blood pressure, what does it mean by like if a number is like over another number? Like, yeah.
Great question. So as you guys have noticed, blood pressure is two numbers. It's the systolic, which is the first number, and the diastolic is the second number. And this is measuring the pressure in your arteries during the cardiac cycle. So when the heart is pumping and when it's relaxing. So the first number is the pressure of blood on your arteries when your heart is squeezing. And that's why it's always the higher number, because the blood is hitting your vessels really hard because your heart just pushed it all out. And then the second number is when your heart relaxes, that's the pressure that your vessels are feeling from the blood. And they're both important. And that's a good question. So yeah. What do you guys think about this patient's blood pressure?
I think it's a regular blood pressure. Because I know that regular is 120/80.
Yep. And what about her temperature?
Too high.
A little bit high.
And then the oxygen saturation.
It's too little. And then also she's getting like she's taking a lot of breaths per minute, but her oxygen is still low. So maybe there's something wrong with so there's something wrong with like how much oxygen she takes in when she breathes.
Yes, I don't even know who said that, but that was great. Thank you. So we have this kind of like, it's kind of the opposite of what you would expect, right? She's taking a lot of breaths in per minute, but her oxygen saturation is still very low. So that's very concerning. It means that her body is trying to get more oxygen, but it can't. And so that is not what we like to see. We like to see our oxygen saturation of ideally above 92, preferably above 95. Okay, so now that we have these vitals and we've heard a little bit about her story, what's something that we want to do for her?
And Dr. TT, I want to let you know while the students are thinking about that, that just a second ago while you guys were talking, I went in and did a quick exam, a physical exam of Jane. And I noticed when I listened to her lungs that they didn't sound normal. They had this really high-pitched whistling sound when she would blow out, and when she breathed in, it sounded like bubble wrap. It was really crackly.
Oh, thank you so much for letting us know. What do you guys make of that? Does that seem to kind of fit in with this picture that we have of her?
Yes.
Yeah, I mean, having trouble breathing, something's wrong with her lungs.
Great. So what should we do? Send her home now?
Wait, I have a question. Can one of the diagnoses be collapsed lung? I don't think so, though.
I also have a question. Can one of the diagnoses be an air embolus?
So I think this is great. What you guys are doing is generating a differential diagnosis, which is a list of different possibilities of what this diagnosis could be. And that is a collapsed lung definitely could be on the differential. That is, so what would make you think that, what are her symptoms that would make you think that this could be a collapsed lung?
When she's breathing in, there's bubble wrap, and when she's breathing out, there's a cracking noise, which is not normal in the lung, which means that there might be a hole in the lung, which can lead to collapsed lung.
So if her lung were collapsed, you'd probably more likely hear a lack of breath sounds entirely, because the lungs aren't able to take in air and they're not able to expand. So you might not be hearing the wheezing and crackles that Dr. Rachel heard on the exam, but she would probably be presenting with shortness of breath. So that definitely could be a sign of a collapsed lung, or atelectasis, as they call it. What makes you think that it might not be a collapsed lung?
She's getting fevers?
I might be wrong, but does breathing stop entirely if the lung is collapsed?
In the part that it's collapsed in, you would not have breath in that area, but you have billions of little alveoli that can take in air. So some air would still be getting in. And I heard someone else say fevers. That's a very, very great observation to make. If this were something like a collapsed lung, she probably wouldn't have signs of fever, which is usually our biggest clue that there might be an infection going on. So that's great.
Someone in the chat too mentioned that her smoking could have done something to her lungs. I think that's a really good thought, and that's something that I think Dr. TT is going to talk to us about a little bit later. So thinking right now, we know that this patient has these really not good sounding lungs. We've got very low oxygen content in the air that she's able to get in. She's having to breathe really quickly. So you guys, on the bottom of the notes, there's a list of what you have in your medical cart. And that might help give you some ideas. But what are some things that we should do for Jane while we're trying to figure out what's wrong with her to help her breathe better?
Maybe oxygen mask?
Yeah, that sounds good. I think that we probably can go ahead and give her some oxygen. So let's go ahead and do that. And after we give her the oxygen, can we just kind of walk away and we're done here, go see another patient?
Well, she also has a fever. I don't know if that's something that should be dealt with.
Another excellent observation. Great. Well, so what can we do for fevers?
Some medication.
Good. What medication do you think might help? Guarantee you all have it in your homes. It's no big secret. It's nothing.
Tylenol.
Yep. Perfect. So we'll give her some Tylenol. Tylenol is a very go-to medication to kind of bring a fever down quickly. And then we'll give her some oxygen. And when we give the oxygen, how will we know if it's working?
Check her oxygen saturation rates again.
Good. Okay, so let's go ahead and see that. So we're gonna give her some oxygen and check her vitals again. So what do we notice now?
The temperature is the exact same and the oxygen saturation still isn't normal.
Yeah, but it is getting better. Like it's improved.
And her
from the
respiratory
first.
rate also improved.
Good, right. So we know that giving her the face mask of oxygen has improved her oxygen saturation. It was 85 before, now it's 90. So it's still not where we want it to be, but it's definitely better. And her temperature didn't go down, and everything else is pretty stable. Okay. So now that we've kind of got our patient stable, she's statting better with the oxygen that we gave her. What are some other things that we can do? Do we have a diagnosis yet?
I don't think so.
Your head. No, we don't have a diagnosis yet. We have some possible ideas. We talked about collapsed lung. Someone had mentioned an air emboli. I'm sorry I didn't get to that question. That's an interesting point. I would wonder where the air had come from. So an air emboli is kind of like a little pocket of air in your vessels that can act as a clot and cause issues if they block blood flow to your organs downstream. So that probably is not one of the top things that we're thinking about, but it is a good point to bring up.
Could one differential diagnosis be, COVID-19?
Yeah.
Because it's a hard time, there's fever.
Yeah, that definitely could be what's going on. How would we know if she has COVID-19?
You would have to test for it because it could also be pneumonia or the flu.
Great. So pneumonia, flu, COVID, those are excellent things to have on our differential, and that's probably the most likely things that this patient could have. So for COVID, we do a test, okay? So we can order that test. It's gonna take a little bit of time to come back. How do we know if she has the flu?
That would also be like a swab test.
Great. Also a swab test. And what about pneumonia?
This is a tricky one, but you guys might have heard kind of how we think about figuring out if someone has pneumonia.
Would it be an x-ray of the chest?
Yeah, you definitely could do an x-ray. That would be helpful. And then we also can do something called a sputum culture. Has anyone ever heard the word sputum before? Or what does it sound like? Sputum. What do you think it might be?
Spit or saliva?
Yep, exactly. So basically the patient is gonna cough up whatever they can get, all that nasty gunk in their lungs, and we want a nice sample of that, and we can send that to the lab and see what it grows. And if this patient had pneumonia, what might you expect to see on the sputum culture?
Pneumonia bacteria.
Yeah, you might see like a certain bacteria that's like taking over, that's just like dividing and uncontrollably, and is like all that's really growing out of this patient's lungs. And if this patient doesn't have pneumonia, what would you expect to see in the sputum culture?
Do you guys think it's normal to see bacteria in sputum or not normal?
Not normal.
Not normal. So it'd probably just be, there'd be no bacteria. It's just spit.
You have no bacteria in your mouths and lungs?
Yeah, I think there is bacteria. It's just like it's not the pneumonia bacteria.
Right. There's certainly lots and lots of bacteria growing all throughout our respiratory system. But like you're right, it's not going to be the types of bacteria that we that cause pneumonia usually, and it won't be one specific type that's just growing and taking over everything. All right, so let's go ahead and look at the results of some of those tests. All right, so I'll give you guys a second to kind of read through this table. The last column here is all the normal normal things. And then here is what our patient's tests showed us, the middle column. Okay. So what do we think about the white blood cell count?
Normal.
That's normal.
Yes. What are white blood cells?
Immune blood cells.
Yeah, that is a very nice, simple way of putting it. They're basically the cells that are responsible for fighting infection in your body. And the flu tests, what do we notice here? Does she have the flu?
No.
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 What about the sputum culture? Who can interpret this? So go ahead and take a look at what it says here and think about what that means based on what we just talked about. And then when you're ready, I would love someone who I haven't heard from yet to tell us what the sputum culture is telling us. Someone who has not said too much. Dr. Rachel, do you want to choose someone?
Sure, I'll choose someone. Let's see. Kaylee, do you want to try this? Don't be worried about the different species. We just want to know maybe what you think about the fact that there are so many species in our sputum.
Maybe one of them is like causing whatever whatever problem she has.
I think that can be a great thought. Do you remember what Dr. Titi was saying about if there's a bacteria that's making someone sick, we would see lots and lots and lots of that bacteria, right? Because it would be growing a ton. So do you think, is that happening here? Or what does it mean that there are a lot of different kinds of bacteria and not just one growing a lot and a lot?
Maybe it's from her previous like illnesses.
Yeah, I think those are some good thoughts that you guys are having. I think anytime we see a sputum culture like this, where it says mixed flora, and then we see all these different species, and something that you guys, we wouldn't expect you to know, but a lot of these species are very normal. They live on our skin and in our mouths and down our throats all of the time. And so those are normal bacteria to have a lot of the times. So we wouldn't necessarily think that she's sick right now, but these bacteria are just living in her lungs like normal.
Right. So do we think that she has pneumonia?
No.
Probably not. She's growing a bunch of different bacteria, and we don't really have like a slam dunk culprit for what could be causing her bacterial pneumonia, if it were a bacterial pneumonia. Okay.
I just have a quick question. Sorry. Would the reference range be like the normal? Because if the normal is no growth and then they're positive for growth, what's the difference between that?
That's a good point. So this is kind of why it's important for humans to interpret data, not just computers, because we know that it could be completely normal for you to see no growth at all if this person had no bacterial pneumonia, but it also could be normal for you to see growth. And that's why we need to really think about the whole clinical picture and when we look at these results. So the reference range is it's a little bit confusing because it says no growth. If we saw that, then we would know for sure that there was no bacterial pneumonia. But just because we see growth doesn't mean that there necessarily is a bacterial pneumonia either.
And another thing that's important to know about Jane, I don't know if you guys remember, but she said she had a long smoking history and she has something called COPD. And so something that happens with COPD is, we'll talk about this a little bit later, but people who smoke for a long time have damaged lungs. And that means that a lot of the gunk and junk in their chest can sit down in their lungs more than it would in someone else. And that mucus is a lot thicker. And so that is kind of a chronic good home for bacteria to live in. So it might be normal for Jane to see more bacteria than you would in someone else because she doesn't have healthy lungs at baseline. We would say at baseline is kind of someone's normal state. And so Jane at baseline probably has a little bit more bacteria in her lungs than maybe you guys would.
That's a great point.
I have a question. Yeah. How long do labs take? Because like, let's say their condition's really bad, and like obviously doctors will need to know like as fast as they can like what type of illness it is. So how long would the labs take to like process?
That's a great question. And if a patient's coming into the emergency room and we need, like in this case, and we need labs as soon as possible, you would draw the labs and then you would put them, you would order them stat, which means that someone will come up and draw the patient's blood as soon as possible and send them to the lab, and the lab will process them as soon as possible. So in our hospitals, I would expect this to take probably a couple of hours for most of these tests to come back. Yeah, that's, and what's important to note is that just because you're waiting for a test doesn't mean that you can't act and treat the patient. A lot of times we have to treat patients without knowing for sure what something is. And that you have to kind of use your best judgment and think about what is the worst thing that this could be and what do I not want to happen, and try and prevent that from happening. So for example, we didn't know what our patient had and we just decided to give her oxygen because it doesn't really matter. No matter what it is, we know that we need her oxygen saturation to be higher. And in the case of certain bacterial infections, we'll actually give antibiotics before we know what specific bacteria is causing the infection. And that's just sometimes what has to happen because we can't wait for results to come back before treating a patient.
Yeah, that makes a lot of sense. Yeah, thank you.
Great questions. Okay, so we have ruled out a bunch of things. What are we thinking now is our leading diagnosis?
It's not a trick question. What do you guys think?
COVID-19, the flu.
Why don't we think it's the flu?
The labs say there's no flu, so.
Right, so probably not flu. So we're thinking most likely this is COVID, unfortunately. And what is another thing that we can do if we want to get more information about our patient's breathing and her lungs and what's going on in there?
Someone asked for a test in the chat that we didn't talk about. It was Brianna. What did you ask us to do? Do you remember? An MRI, yep, that's right. So an MRI is one way that we can look inside someone's chest, but there's actually a better way that we can get more detail? What's another way besides MRI that we can look inside someone's chest?
Exactly.
Yep. Good job.
So a CAT scan is basically just a 3D X-ray. So that's going to give us a really nice picture of what's going on in the lungs. We heard some things. Remember, Dr. Rachel told us that she heard some crackles and wheezles. So those are sounds that the lungs make when they're not doing very well. And now we can get a better idea by doing a CAT scan. So let's go ahead and take a look at that. And just to orient you guys, so when we look at images, what you see here on the left side of the image is actually the right side of the patient's body. So it's kind of like where if you cut the patient open like this, in this picture here on the left, and you were looking up into their internal organs, that's the picture that the CAT scan is taking. And so let's just see what we can make of this picture here. So this is a normal CT scan of the lungs. What is this organ here, right in the middle? Anyone? Just yell it out.
A heart.
Heart.
Great. And what is on either side of the heart here?
The lungs.
Lungs.
Great. And what do you want to see? What should your lungs be filled with?
Alveoli.
Yes. Alveoli filled with air. Exactly. And air on CT and X-ray looks black. So we want to see mostly black here. What do you guys think these like white lines are?
Arteries or capillaries?
Yep, exactly. So those are the vasculature or the vessels in the lungs that we can see there as well. So that's all normal. Let's take a look at what our patient's CT scan looked like. So what do we notice here?
There's a lot of white, or not black, which means there's not a lot of air in her lungs.
Mm-hmm.
And they also look misshapen, kind of decayed.
Yeah. What do you think that's from?
Or smoking.
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 Exactly, right.
And so what do you guys think? I think you were right. It doesn't look like there's a lot of air. There's a lot of white in there. What is that white stuff? What might that be?
Mucus.
Good. What else?
Like fluids.
Fluids, good. And can you understand when I heard those crackles, it's like all those little alveoli popping open against the water, right? And so that's what we hear. When you hear crackles in the lungs, you're hearing these little tiny alveoli snapping and popping open. The same way you can think about like if you blow water into a balloon that's shut and filled with water, it'll pop open like that. And that's what we hear. We describe it as Velcro ripping apart. That's what it sounds like when a million little alveoli pop open in the water.
Great. So her lungs aren't doing too well. We see that there's a ton of fluid in them, and it makes a lot of sense that she's having so much trouble breathing, right? We would not want these lungs. Okay, and I think we just wanted to briefly talk about the respiratory system. So you guys, we've kind of already talked about this, but in the center of your chest, you have your trachea, which is colloquially known as your windpipe or airway. And it branches off into the bronchioles and the alveoli, which fill with air in either lung. And so this is what our patient's lungs probably look like at baseline. Dr. Rachel was talking about. When someone smokes cigarettes for many, many, many years, the cigarette smoke destroys the tissues in the lungs, and the alveoli, which are usually like nice, like round balloons that can fill up with air when they need to and then collapse when they need to when you exhale. Those alveoli become destroyed by all of the cigarette smoking, and they can't really expand and collapse as they normally could. And then bronchitis, which also is part of this umbrella term called COPD, chronic obstructive pulmonary disease. It's basically a lot of inflammation, a lot of mucus buildup in the lungs. What do you think can happen when there's a lot of inflammation and mucus building up in the lungs?
Can't have oxygen.
Right. Mm-hmm.
I see a chat that says air cannot flow freely. That's a good interpretation.
Exactly. Right. So this is why people who smoke anything, but in particular cigarettes, are at increased risk of developing complications from COVID-19 because at baseline their lungs are so they're so weak and they're not functioning well, and so anything else that comes in and affects the lungs can then really cause them to lose their ability to breathe, to take in oxygen. Okay. So,
if possible.
Yes.
Aside from the actual smoke, is there an impact that tobacco or nicotine specifically has on the lungs?
That's a really good question. What do you think?
Yeah, I think yes. I think there's a lot of research that's been done about different types of smoking and the impact that it has. And so I think the most important thing is that any substance that you breathe down into your lungs are so fragile. They're so delicate, and they're down to like one cell layer thick. I mean, they are just so fragile. So anytime you take substances in that don't belong in your lungs, it causes a lot of damage and a lot of inflammation. And those alveoli are very sensitive. So the different compounds in cigarettes and in tobacco are very harmful. But also, you guys have probably maybe heard a little bit, vaping really kind of started coming in a couple years ago, and some people would say, oh, it's not as bad for you because it's not tobacco, it's not cigarette smoke. But actually, they've found that all of the chemicals and substances when you use e-cigarettes has a similar effect. It's very damaging to your alveoli. So I think my answer would be yes, cigarettes contain substances that cause damage. Nicotine more is just the addictive quality. That's not necessarily a toxin to your lungs. It's all the other compounds when you smoke. But anything that you're breathing into your lungs and smoking, including e-cigarettes, marijuana, all of those substances can and do cause a lot of damage to your lungs.
Thank you.
Was there another question? Okay, so we got the results of our COVID-19 test finally, and surprise, surprise, it is positive. Okay. So why don't we go ahead and we're gonna need to talk to our patient, and we're gonna need to let her know that she has COVID-19. We also kind of want to know what else. What are some other things that we want to know at this point?
Who they've been in contact with.
Mm-hmm. Great. And what about in terms of her health and how she's doing right now?
How serious it is? Should she like self-isolate, or should she need assistance, have to stay in the hospital?
Great, exactly. And Brianna said in the chat, a third round of vitals. We need some information to help us decide exactly that. Does she need to stay in the hospital, or can we send her home to kind of self-isolate and kind of take care of herself at home? So let's go ahead and look at her vitals again. So now what do we notice here?
I mean, her heart rate is now higher. Her blood pressure is really different than it was before.
She's breathing way, way, way faster than normal. She's getting lower oxygen levels than normal.
Great.
Dr. Titi, I'm really sorry to interrupt you guys, but I do not feel good and it's really starting to scare me. I can't breathe. I kind of feel like I'm drowning and I can't lay down and I'm getting really dizzy and I don't know what's going on, but I need some help, you guys. I really, really don't feel good at all.
Oh, I'm so sorry to hear that, Miss Doe. Let me just talk to my medical students here and see what they want us to do.
Okay, just go quickly because this is getting really scary, guys.
Well, we'll be right with you, all right? We'll talk and then we'll come back and tell you the plan, okay?
Okay.
Okay, guys, so we just kind of checked in with our patient and we looked at her vitals. Are you guys worried?
Yes, because everything went
Because
forward.
it's been before, which means that it's impacted her more.
Yeah, it looks like she's not doing well at all. I'm really concerned here. I'm seeing her high heart rate, her low blood pressure. I'm starting to get really concerned here. You know, I haven't lost a patient yet in my career. I mean, I've only been a doctor for like 2 days, but it's like I can't handle this. I really need some help. What should we do? I don't know what to do.
Should we take her to a room and give her like a ventilator?
A ventilator? Oh, wait, how is that going to help?
The oxygen saturation will go up, I think.
Okay, yeah, that sounds like a really good idea. I'm really concerned that she's not breathing well and we need, oxygen to live. So it makes sense that we might need to put her on a ventilator. What are some, okay, so why don't we go ahead and get that going? Can we just put her on a ventilator right here in the emergency room?
It has to be sterile, because whatever's around them can like get in and infect their lungs.
Exactly, and there's a special place in the hospital for patients who need a ventilator.
The ICU.
Also, is there some sort of medication to normalize blood pressure?
Yes, that is a very good point. And all of those medications need to be administered in the ICU specifically, like Brianna said in the chat and someone else said. So we need to take this patient to the ICU. I will call the patient's family and let them know what's going on. And we'll take the patient to the ICU and put her on a ventilator. So let's talk a little bit about intubation and what the process of putting someone on a ventilator is like. So there's this really short video here that I will show you guys that really just does a nice job of showing how to intubate someone, which means to put them on a ventilator. Okay.
Your doctor will tilt your head back slightly and insert the laryngoscope through your mouth and down into your throat, taking special care to avoid contact with your teeth. Using the blade, your doctor will gently raise the epiglottis, which is a flap of tissue protecting your larynx. He or she will then advance the tip of the endotracheal tube into the trachea. Once the endotracheal tube is in the trachea, your doctor will inflate a small balloon surrounding the tube to make sure it remains snugly in place. Your doctor will remove the laryngoscope and tape the tube to the corner of your mouth to prevent it from being jostled out of position. Your doctor will check to see that the tube is properly positioned in the lower part of the trachea by inflating your lungs with a special bag and listening for breath sounds on both sides of your chest. If the end of the tube is too low, both lungs will not.
I'm sorry, guys. Let's see.
I think you have to switch it to share your Safari window or your internet window.
You see it now?
The endotracheal
Yep, you got it.
tube to its proper position.
All right, well,
Lightly, and insert the laryngoscope through your mouth and down into your throat, taking special care to avoid contact with your teeth. Using the blade, your doctor will gently raise the epiglottis, which is a flap of tissue protecting your larynx. He or she will then advance the tip of the endotracheal tube into the trachea. Once the endotracheal tube is in the trachea, your doctor will inflate a small balloon surrounding the tube to make sure it remains snugly in place. Your doctor will remove the laryngoscope and tape the tube to the corner of your mouth to prevent it from being jostled out of position. Your doctor will check to see that the tube is properly positioned in the lower part of the trachea by inflating your lungs with a special bag and listening for breath sounds on both sides of your chest. If the end of the tube is too low, both lungs will not receive the same amount of air. In some cases, an X-ray is taken immediately after intubation to confirm the tube's placement. Once the
okay. All right, so we intubated the patient, and here are some of the controls.
You may receive endotracheal intubation and mechanical ventilation.
Is that me?
Respiratory problems.
Okay. So we were going to talk a little bit about the different settings on a ventilator. Dr. Rachel, in the interest of time, did you want to maybe briefly talk about this and then do the debrief?
Oh, there we go. Yes, I think that sounds great. So I am actually working in this hospital learning to be a pulmonologist, which is a doctor that works with lungs. And so I have a lot of experience with a ventilator, which is what you guys rightly decided to do for this patient to help her get her breathing better. So what do you guys think makes a ventilator different from an oxygen mask? Why is that what we decided to do here?
Does a ventilator like help the lungs work, but an oxygen mask just provides more oxygen?
Yes, you're on the right track. So what do you mean when you say it helps the lungs work?
Like, does it help it pump more, or does it like aid the forces like air into the lungs so that even if they're not like really working like well, then
The way kind of just breathes for you.
Perfect. Yes, you guys are exactly right. So when we give someone an oxygen mask, all we're doing is making it so that the air that they breathe has more oxygen in it than normal. The patient still has to breathe on their own, right? So if we put someone on a ventilator, that breathing tube is all the way down right on top of their lungs. And so the machine is able to inflate the lungs for them. That is going to be especially important for someone like Jane, because remember, she has been smoking for a long time. Her lungs are pretty damaged. So it takes a lot of work for her to get the air in her lungs. And I see a really great question here. Someone asked, how would they exhale? So what do you guys think about that? If there is a machine that's pushing air into her lungs to expand them, how does she get that air out? Everyone let's do this together really quick. Everyone take a big deep breath in and then let it out. What do you think?
It also takes air out.
So when you take a big deep breath in, what are you doing? We guys all expanded our chests, right? And picked our shoulders up and tensed a bunch of muscles to make our chest as big as we could. What happens when you exhale? What happens when you let it out? Are you tensing all your muscles up?
You're letting your lungs deflate and relax.
Perfect. That's exactly right. So if you think about the way that your rib cage is and the way that your lungs work, when you take a big breath in, you use all your muscles and you pull your rib cage out, right, to make more air. And as that happens, your lungs, which have all these nice little air sacs, there's less pressure in your chest, right? Because hopefully you guys have done some physics, but when you make the volume of your chest bigger, that pressure goes down. And so air is going to rush in when you inhale like that. And then when you exhale, when you relax those muscles, it's going to push some of the air out, but that's just a relaxing process. So you can think about your lungs kind of like a spring, right? So when you inhale, you pull that spring really, really tight. You're using your muscles and you're using force to generate some tension to make room for all of that air. But eventually that spring is gonna, when you relax those muscles, it goes back into place. That's exactly what your rib cage does when you exhale, and your lungs kind of spring back to their original shape. So if you think about crackles, when you inhale, you're forcing those lungs to open up a little bit, you're letting air in. And then when you exhale and those lungs collapse, that's why the alveoli, if there's a lot of excess fluid at the bottom of your lungs, they'll squish together like that because of all that pressure. Does that make sense to you guys? There are some good comments in the chat box, but this is a confusing concept sometimes even for medical students. So hopefully, does that make sense? Oh, someone gave me a thumbs up. That's great. Any questions about that?
What if you do it too high in the bronchi or like in the trachea? How do you like change the position of the ventilator or the tube? Sorry.
Yeah, that's a good question. We can just move the intubation tube if we need to. That's why, like, they said that sometimes you'll want to be able to x-ray to make sure you got it in correctly. And that is an important thing that we can do sometimes to double check, but you can just move it. But it's very tricky, and it's important to do an intubation correctly because that can be really dangerous. If you put the tube in the wrong place, sometimes it'll go down the esophagus instead. That can be dangerous, and sometimes you can poke a hole in someone's trachea. So you have to be very careful, and doctors do a lot of training to make sure they can do that correctly. And I'm going to, TT, if you want to pull the PowerPoint back up, or I can start sharing it as well. So you guys did a great job thinking about, perfect. Let's go to the slide that just shows the patient with the ventilator in place. I think it might be one or two more. Yeah. So what are some things, if we have someone on a ventilator, there are all sorts of different settings, right? Because patients need different amounts of oxygen. We have to help them breathe depending on how much air they need. So what are some things we might have to set on a ventilator? What are some things you want to be able to adjust and control for your patient?
The rate of airflow?
Good, rate of airflow. So what do you mean by that?
How fast the air is going, depending on how much air they're getting.
Good, great job. So how much air, how quickly the air is going in the tube, right? Because we want to make sure we give them enough. But like I said, those little alveoli are very, very delicate, right? And we don't want to blow too hard or you can damage them. Good. What are some other settings we might want to control?
Someone said air pressure in the chat.
Air pressure, yes, that's a great one. And let's think about air pressure a little bit. This is going to be maybe a trickier question, but I've been very impressed with you guys, so I think we can definitely talk about this. So I talked to you about how this patient has crackles, right? And that means their alveoli are collapsing. And that happens if you think about, I had a doctor explain it to me as your lungs are kind of like a sponge. And if your lungs get wet like a sponge, they get really heavy and they start to fill up with water, and there's a lot of pressure around those alveoli. And when there's all that water and pressure, the alveoli start to collapse when you exhale out, and that makes it really hard to breathe in as well. So when we think about how much air pressure there is in the lungs, what is maybe something that we could do to help the alveoli stop from collapsing? What do you think? Do we want to let all the pressure out? Do we want to have, so someone said reduce air pressure. So let's think about that. If we, at the end of the exhale, if it's really low pressure, what does that mean is going to happen? The alveoli are going to close, right? Because it's low pressure inside the alveoli and high pressure from all the water outside, right? So it'll squish our poor little alveoli. So what might we do instead?
Higher air pressure then.
Higher air pressure, good. And that's something we call PEEP. It's PEEP, and it stands for positive end expiratory air pressure, okay? So what that does is if we keep just a little bit of pressure in the patient's lungs, it can help make sure those alveoli are, we call it ventilating correctly, that they're getting enough air. And it actually can also help minimize the amount of water in the lungs. It gives a little bit of pressure to push some of that extra water, and it actually can go back into the capillaries, into the bloodstream, and help resolve some of, this is a big $100 medical word, but pulmonary edema, so too much fluid in the lungs. So that's great. Let's go ahead to the next slide, TT. I think they did a great job thinking about some of these settings. So this is what the readout of a ventilator might look like. And there's a lot of labels that are complicated beyond what we need to talk about today. But if you look at that little table on the right side, these are some of the major settings that a pulmonologist might control on a ventilator. So one is tidal volume, and that is how big of a breath is your patient taking in and out. So we want to make sure that we try to fill up the lungs, and then we can empty them back out again. Respiratory rate is something that you guys have already been looking at with our patient. So how quickly are they breathing? That can be important because in addition to taking oxygen in, breathing lets you get carbon dioxide out too, right? So we want to make sure that we have a good balance of both of those. FiO2, what do you guys think? Has anyone heard of that before? Okay, that's a different one. This is something that changes with an oxygen mask too. So that stands for the fraction of oxygen that you're giving the patient. So does anyone know in room air at sea level, what is a normal percent oxygen in the atmosphere? The concentration of oxygen, yep, it's a percentage. Does anyone know what percent of the air that we breathe is oxygen normally?
20, I think.
Perfect, exactly, 20%. So we call that room air. And you'll see, like on the picture here, it says FiO2 is 60%. So instead of 20%, we're giving a patient 60% oxygen. So that's something that we can do to help someone get their oxygen saturation up if they're struggling. And then PEEP, P-E-E-P, is what we just talked about. So that's that little bit of extra pressure that helps the patient empty their lungs all the way, and it helps keep the alveoli from collapsing down. So great job, you guys. This, all of this ventilator medicine is really, really complicated. There are doctors who go to school for a very long time to learn how to take good care of patients on a ventilator. So you guys did a great job with this. This is a tricky slide, so really, really good job. And let's go ahead to the next slide.
Oh, it looks like, what was the major thing that changed when we put our patient on the ventilator?
The oxygen saturation and the respiratory rate.
Perfect. And are they looking better or worse?
Better.
Definitely better.
Great. So now that we've supported our patient's breathing, we can actually give our patient the time that she needs, her body needs to kind of fight this virus on its own. As I'm sure you guys are aware, there aren't too many treatments that we have. Actually, there aren't any treatments that we have for coronavirus specifically. So it really is a lot of supportive care of making sure the patients can breathe. and that their bodies have what it needs to fight off the infection on its own. So at this point, yes.
So I've heard a lot of things on the news that hospitals are being overflowed with people that have COVID-19 and there's not enough ventilators. So what would you do with the patient where there's no more ventilators left for them, but they need it?
That is an incredible question, and we could talk about that for hours. There's a whole field of medicine called medical ethics that focuses on something called resource allocation, which basically means, or like triaging, basically means like exactly what you said. We don't have enough ventilators for every single person necessarily who might need one. So how do we decide which patient gets one over another patient? What are some of the things that you guys think might make one patient get the ventilator over another patient?
Age?
How old they are?
How old they are. Let's think about that. So if someone comes in and they're 75, they are having trouble breathing, and we have another patient who's 30 and also is having some difficulty breathing, you guys think that the younger patient should get the ventilator, is that right?
Well, I think you could see it both ways because I guess the younger patient has more chances of living, so it's a better use of the ventilator, but probably the older person has a weaker immune system, so they need it more.
Yeah, that's a really good point. You could look at it both ways, and that's what makes it really so difficult to really decide. I think the way that they kind of think about it is we want to maximize the the number of people that are going to survive. So you want to look at who needs it more. You also want to look at who will likely benefit from being put on the ventilator. And so it's a very complicated decision.
I have a question. Like, so if someone was on like a ventilator for like a long time, but there's like no changes, would you give the ventilator to someone else new?
That's a good question. What do you think about that, Rachel?
Yeah, that's a really good question. So you guys are asking the kinds of questions that doctors who are in charge of hospitals have to ask themselves every day. And I think probably what you're already starting to realize is there's no good answers. There's no easy answers to those questions. And that's something that's really difficult. And it's also very interesting, I think, because TT and I obviously live in America, and our healthcare system is different than what you guys have in Canada too. And that brings up some really interesting discussion points. So I think to answer the question that was just asked, typically in America, and I'm actually not sure how this works in Canada, so you guys might be able to teach us something, but generally once you give a patient a ventilator, you do not take that patient off of the ventilator by choice. So if someone comes in and is put on a ventilator, they usually will get to stay on that ventilator until they pass, essentially, or until it's determined that without the ventilator, they don't have a chance of surviving. And that also gets into some conversations about end-of-life decisions. And those are also things that individuals and families kind of decide together, is do they want to keep their loved one on a ventilator for a very long time? Or do they want to decide to stop the ventilator and let their loved one pass away? And those are really difficult conversations for families and doctors to have. And like TT said, there are a lot of people who study that for a living. I mean, we definitely need good critical thinkers and good compassionate decision makers when it comes to those things. So I think you guys are asking the right questions, and there's no good answers to all those questions, unfortunately.
Right.
I have one more follow-up question. So let's say someone who comes in doesn't qualify for a ventilator and you can give them one. Do you just send them home to die?
So
I think,
if a
yeah,
patient
go ahead, Tiki.
if a patient needs ICU level care and there aren't any ventilators available, I definitely don't think you would send them home. I think you would try to do whatever it is that you have within your power to support them. So there are other things besides a ventilator. Nothing can replace a ventilator. If you need to be intubated, like that's really what you need. So like the face mask, we saw how that helped a little bit for a little bit until the patient got worse and needed to be intubated. So there are other things that you can do to support the patient's care, but without a ventilator, the patient likely will not be able to survive if that is what they need. So you can do things like try to find another hospital in the area that might have some resources available. You might, I mean, I'm not, I would hope that, I'm just glad we haven't really come to that point because I'm not really sure what, you're really out of options at that point. And I think that's why it's so important that we are taking all of the precautions we can to make sure that we don't get to those numbers where we're out of ventilators, because at that point you really have very, very limited options. Do you have any other?
Yeah, I think this is a good time to kind of transition to our COVID recap maybe, and we'll get into some of the conversations about this, and then we'll take your guys' questions. So just to round out the case, back as Jane Doe, but you guys did such a great job with my care. I feel so much better. And what are some things now that I am feeling better and ready to go home? What are some things that you guys want me to know before I go home? Can I just go home and live my life as normal? What are some things that I should think about?
Self-isolation.
Maybe, yeah, self-isolation, just to make sure you don't have it and you don't give it to anyone else.
Good. And how long should I try to stay by myself for?
14 days.
A month?
14 days, I think, is generally what we've been telling people. And is it 14 days as soon as I'm home? What if I still have a cough?
14 days till the cough? Till the cough?
Yeah, so usually I think right now the guidelines are 14 days after your symptoms resolve. So as soon as my fever goes away and I start feeling better, you want to generally wait another 14 days before you start to come in contact with people. And what about, Mrs. Doe was saying that she doesn't see too many other people, but she went and saw her neighbors. I think she said her daughter comes over sometimes. What should we tell her about those people?
They might be at risk, so that they should probably get tested.
Exactly. And should they get tested right away, or how do we kind of decide who needs tests and who doesn't?
She probably sees her daughter more recently than her neighbors, so I think maybe the daughter's like more urgently needs to be tested. I remember she said she was in contact with her neighbors 2 weeks ago, or like a couple weeks ago, which I guess we should ask her to clarify on if it was like within that 14-day incubation period.
Good, yeah. And I see Trinity in the chat also said, tell them to monitor for symptoms, and that's exactly right. And unfortunately, for a while, there was also a little bit of a shortage of tests just because everything happened so quickly. And so that's one method of allocation, like TT was talking about, that we kind of saved tests for people who were showing symptoms, because those were people that we were wanted to make sure that we got tested. And someone is asking, what if they're asymptomatic? And I think that's another thing we hear a lot about, especially younger, healthier people can have COVID and maybe not even know. And so that's why it is important. You guys are on top of it. Someone just put this in the chat as well. But that's why it is important to follow guidelines for staying in isolation after you've been exposed, and making sure that you wear masks, trying to do social and physical distancing when you're out day to day, because any way that we can minimize contact is a good way to minimize spread. And that will really help us, just like you guys just said, to keep our healthcare systems from getting overrun. So I know we're over time, but let's just run through a couple of quick facts about COVID, and then we'll take any questions you guys have. So this is just a slide talking about the progression of coronavirus. So the incubation period, that's kind of when we think about someone has the virus, it's replicating in their body, but they don't have symptoms yet. And that's about 5 days. And then they might start to have some symptoms. So those are things like fever, cough. Sometimes people will just say they feel fatigued, they don't feel well. Some people will have nausea. I'm sure you guys have heard there's a lot of different presentations of coronavirus, and that's why it's hard to track it sometimes. And then after a while, we start to get into this more severe form that a very small percentage of people have, but people who do can get very sick very quickly. And that's like what happened to Jane today. So that's things. Dyspnea is a word that means it's hard to breathe. Tachypnea means that someone's breathing really quickly because they're having a hard time breathing. And then hypoxemia means that they don't have enough oxygen in their blood. And that's all things that we were seeing today. And ARDS is a word that we'll talk about on the next slide. So that's kind of the timeline. And the reason that coronavirus is so difficult is because that early phase where you don't feel symptomatic is quite long and it's very contagious. So people will spread the disease and not even realize it. And that's part of why it all started to escalate really, really quickly across the globe. It's just a very, very contagious and a really sneaky virus. So we'll go to the next slide. And talk about kind of some of the more severe forms. So like I mentioned, most people thankfully get a relatively mild form of the disease. It's similar to a flu, a bad respiratory illness, something like that. And so that's great. But people who have more severe manifestations are people who have risk factors. And the biggest risk factors are pre-existing conditions, especially things involving the lungs. So a smoking history, COPD, chronic bronchitis, anything that makes your lungs more susceptible to infection can increase your risk. And then people who are immunocompromised. So that is why we think a lot of older people tend to have higher risk, because as you get older, your immune system's just kind of tired, is how we describe it sometimes. And it can't fight off diseases as effectively sometimes. Also, I know someone mentioned earlier they have a friend who is immunocompromised. That can happen for a lot of reasons, for different pre-existing conditions, different diseases, and even some medications can make it easier for someone to get an infection. And so when that happens, we can progress to a more severe form. And this is something called acute respiratory distress syndrome, or ARDS. And that's, if you remember the CT we saw, that's all that fluid that builds up in the lungs. So where do you guys think the fluid is when you have acute respiratory distress syndrome?
In the alveoli?
In the alveoli, right? That's where it looks like. And how does that fluid get there?
Where is it coming from? Through the blood, someone says in the chat.
Through the blood. Can you explain that a little bit more? Or does someone want to help?
Maybe the capillaries that are close to the alveoli.
Perfect, exactly. It comes from leaking blood vessels. That's exactly right. You guys have got it. So anytime you have an infection, your body has what's called the inflammatory response. And that's a way to get all those white blood cells that make up your immune system to the site of the infection so they can try to clear it up. And so when that happens, your capillaries get leaky and they literally will start to dilate, and their membranes will change so that white blood cells can get through to fight off the infection. And when that happens, fluid can leak out as well. And that's what causes this buildup of fluid in the lungs. So that's very good. Awesome. And then let's go to, and what we can do to help, exactly like you guys said, if we can clear the infection, and then sometimes if someone needs a ventilator, that PEEP can be helpful as well.
Is it possible to drain the liquid from the alveoli?
Yeah, so that's an interesting question. How might that work? So in the interest of time, I know we're running over and I want to be cognizant of that. TT and I are happy to stick around as long as you guys have questions. But to answer that question, it's really tricky to suction fluid out. That's not something that we do for patients, because if you think about it, it's pretty dangerous because the alveoli are so delicate. And also, if you were to think about, if you tried to suction the liquid out of the lungs, there are trillions and trillions of tiny, tiny little alveoli, right? So there's just no way that you can suck all the fluid out. But when we use, yeah, someone was like, yes, there are too many of them. That's exactly right. So when we use that PEEP, it pushes the fluid out of the alveoli and into what we call the interstitial space. So just outside of the alveoli, and then it can be reabsorbed by the capillaries over time. So that's a more effective way. And then just briefly, I know you guys have questions about this, so maybe we'll let you guys ask specific questions, but all of the things that people around the world have been doing to stop the spread is to avoid exactly the problem that you guys brought up, which is if too many people get really sick, we worry as doctors and healthcare providers that we'll run out of ventilators, of hospital beds, of supplies. And a big problem that we ran into early on especially was PPE, so protective equipment for nurses and doctors and healthcare workers to help them prevent the spread of COVID between patients and also to the doctors and nurses themselves. So when you have too many patients who need really acute high-level care, it's really hard sometimes to have the resources and the providers to care for all of those people and give them the care that they need. So we're in an interesting time, I think. Thankfully, a lot of places around the world have started to see their cases go down. But looking forward, I know people were asking questions about herd immunity, how long this will be, things like that. I'm going to give a disclaimer that unfortunately, TT and I wish we had the answers to those questions, and all of our teachers and physicians also wish they had the answers, but no one's really sure. We've never faced this disease before. Herd immunity is something that would take, I think, a long time to develop, and that's why so many scientists are working really hard to get a vaccine very, very soon, because that would be the way that we could get herd immunity without having to really expose lots and lots and lots of people to a disease that can be really harmful. So right now, there are still guidelines in place to minimize contact because we don't want to overrun the healthcare system. We want to try to keep cases as low as we can for as long as we can so that we can make sure that we take care of people who need expert and extra care in the hospital. And how long, unfortunately, we don't know. I know that research is changing every day in regards to how many cases there are, how many people are immune already, what the most appropriate guidelines are to think about physical distancing, while some economies are also trying to reopen and a lot of people are dealing with hunger and joblessness. So it's a lot of really big questions, and we're happy to stay on and kind of talk about this as long as you guys want.
Could you just briefly go over what herd immunity is?
Yeah, definitely. And TT, I'll have you fill in, but essentially, when we think about herd immunity, you have to hit a critical point of people who have been exposed to a disease and have immunity against it now. So you've probably heard about the serum antibody test, but can anyone explain to me what antibodies are? You guys are like, we've been on Zoom forever. I agree. So antibodies is just after you have been exposed to an illness before, you actually have white blood cells that specialize to fight that disease. And once it's gone, those blood cells kind of stick around and they're called memory cells at that point. And so the next time you see that virus, those memory cells wake right up and make a ton of antibodies. And those antibodies just kind of cover the bug, whatever's infecting you, and make it easier for the rest of your immune system to kill it. And someone is mentioning ideas about reinfection. again, it's active research, I think, and we're not sure. And that's why I think a lot of doctors and governments are still recommending that we try to be really good about hand hygiene, be good about wearing masks, try to do distancing as responsibly as we can, because we don't know, unfortunately. But TT, do you have anything to add about the concept of herd immunity?
No, I think that's really great. Yeah, I think just to stress that we have more questions than answers right now, and even with the antibody test, we're not even sure if the antibodies provide immunity from a future infection or how much immunity they provide or those types of things. So I guess it's to be determined. Yeah.
Yeah.
With that, we are now 30 seconds over.
Thank you so much, TT and Rachel. If anyone has any more questions, they can email us and we can forward them to you if you guys have time to answer them later.
Great.
So thank you so much. We definitely learned a lot from you guys and it was really fun. And thank you everyone for being so engaged and interactive.
You guys were an amazing group and I'm so impressed by everything we were able to come up with. So definitely, if you guys want to go to medical school, I think it's a great career. So keep in touch.
Totally. Thank you guys so much. You were a fantastic group. This is a real pleasure for us as well.